Good evening and welcome everyone. Thank you so much for joining us today. I know England is playing, so well done to everyone that's joined us. We've got our usual team here today. My name is Mikey Adamczyk. I'm a consultant here in Surrey and in London. And we've got the whole CMIC London team here, starting from the top with Avril Baci, who is a senior registrar. And Avril, you're gonna come join us in St. Peter's soon, aren't you?
Yes, in October.
Charlie Cutler, who is a ST4, Flo Britton, ST5, and Ben Mondelli, who is going to be a consultant in Guildford soon. We have a very good friend, Professor Mabrouk, who is joining us today as a featured article today. The way we usually run the Legenda is we will have a couple of short articles that we will go through in the first 5 to 10 minutes, and then we will have a featured article who is Professor Mabrouk will speak to us about today, and then we can take some questions on it. If you do have any questions, please type them down on your Q&As, and then we can go through all the questions together. And at the end, we will have a couple of small articles to go through. Big thank you to EL for helping us to organize this, and to Carl Storts for supporting us, specifically John. And who is starting with the first article? Is it Avril or Charlie?
It's me. It's me. Cool. So the first paper I looked at was a systematic review and meta-analysis of randomized control trials looking at probiotics and symbiotics to reduce infectious complications after colorectal surgery. And you can go to the next slide, Avril. So this is a large meta-analysis of 21 randomized trials, including 15 probiotic and 6 symbiotic evaluations, and demonstrated the effectiveness of these interventions in reducing infections after colorectal surgery. Some of the primary outcomes studied were overall infectious complications and surgical site infections, while the secondary outcomes they looked at included pulmonary and urinary infections, wound infections, and anastomotic leaks. The results indicated a notable reduction in infectious complications with probiotics and symbiotics, particularly in the pulmonary and urinary infections, emphasizing their potential benefits in colorectal surgery. And the study highlighted the need for further investigation into the best formulations and duration of probiotics or symbiotics before they can be included in enhanced recovery programs after surgery. Next slide, please, Avril. So this table summarizes the characteristics of the included RCTs. The methodology ensured a comprehensive and structured approach to analyzing the data from these RCTs. The inclusion criteria included RCTs evaluating probiotics and symbiotics in colorectal surgery and excluded Congress abstracts. And then the comparators considered were probiotic/symbiotic versus placebo or standard care, ensuring a clear evaluation of the interventions. And the methodological quality of included RCTs was evaluated using the JDAD scale to ensure the reliability and validity of the studies. And then you can go to the next slide, Avril. And this table 2, the slide before, table 2 just demonstrated the details of the strains of the different probiotic and prebiotics used in each RCT. So onto the results slide. The meta-analysis included a total of 1,961 patients, with 973 in the probiotic or symbiotic group and 988 in the control group, showing a significant reduction in infectious complications in the probiotic/symbiotic group compared to the control group. The primary outcomes revealed significantly fewer infectious complications with a relative risk of 0.59 and fewer surgical site infections with a relative risk of 0.7 in the probiotic or symbiotic group. Secondary outcomes included significantly fewer pulmonary infections with a relative risk of 0.35 and urinary infections, a relative risk of 0.41 in the probiotic and symbiotic group, highlighting their sort of broader benefits beyond just surgical site infections. And then to the conclusion slide. This meta-analysis confirmed the efficacy of probiotics or symbiotics in reducing infectious complications after colorectal surgery, with a significant reduction in overall infectious complications and surgical site infections in the probiotic group. This could have really exciting applications in future for minimal access surgery in gynecology, where when we're excising deep endometriosis, we often have to perform, rectal shaves, disc excisions, bowel resections. The effect size was found to be higher for non-surgical infectious complications such as the pulmonary and urinary infections, indicating the potential of the probiotics and symbiotics in preventing these specific type of infections. And that's that.
Okay, thank you. Thanks, Charlie. Do you know what probiotics they use?
What was that, sorry?
What type of probiotics that they use?
They use, well, if you go back to table 2, they had a mixture of lactobacillus, streptococcus, I think, and then in terms of the prebiotics, they use certain oligosaccharides, oligofructose, etc. I didn't know the exact protocols though.
Okay, and there was, so correct me if I'm wrong, but looking at your presentation, there was definite improvements in UTIs, in pulmonary infections, but not significant improvements in colorectal sort of complications. So anastomosis leak
So
was...
yeah, in terms of anastomotic leaks and wound infection, there wasn't a significant difference, but in things like surgical site infections around port sites and things, there was. But no, there was no difference in terms of anastomotic leaks and wound infections.
And how long did those patients have to be on probiotics for?
There wasn't sort of a strict sort of protocol. I think each study had different sort of lengths of time. I'm not sure on the exact lengths of time for each.
Okay. That's interesting. Mohammed, do you ever sort of use probiotics for any of your patients, Professor Mabrouk?
No, actually not. Maybe we might think of starting at some point, because the results are encouraging, because even if you reduce the other source of infection by 21 randomized controlled trials, nice meta-analysis, that's also good. The question is, why not? You know what I mean? And even if it's not reducing the risk of bowel or anastomotic leaks, etc., but we do sometimes heavy work, and one of the nightmares that you are afraid of after surgery is infection. You know what I mean? When you do reimplantations or massive dissections, or one of your nightmares is having a pelvic abscess or any infection after this type of surgery. But yes, it is. We just need to go in depth and see what and for how long and which one. You know what I mean? I think. I'm not sure if you have experience with this. Do you use them, Mikey?
No, we don't actually. To be honest, I think probiotics in general are so underestimated in general practice, because we completely skip by it, and in modern medicine we don't use it as often as I think we should. So that's definitely something to look into. But the results that Charlie showed us are really encouraging. So that's definitely something that we will need to pick up. I see Shaheen has joined us as well. So hi, Shaheen. Right, what's the second small article of the day?
Okay, my second article is on a paper by Professor Horace Roman and his team. And this is a paper looking at the duration that it takes to stop intermittent self-catheterization for those who required it after deep endometriosis surgery, and then to look at the risk factors that are associated to it. So sorry for this wordy slide, but essentially in a nutshell, this was a retrospective study. They included all patients with endometriosis who were operated on, and they excluded patients who were already on intermittent self-catheterization preoperatively. In terms of their bladder voiding symptoms, they used the last 3 questions of the urinary symptom profile questionnaire, which included: how do you describe your usual urination? How do you describe your flow? And how has your urination been? And the higher the number is, the worse your symptom is. And then in terms of their clinical practice, so all patients who were operated on, once they were able to mobilize, they would have their catheter removed. And after the first void, they would measure their post-void residual. And if it still remains above 100, these patients were monitored throughout their inpatient stay. And if at discharge and their post-void residual was still more than 100, then they were trained to perform intermittent self-catheterization at fixed times during the day, usually about 5 times a day. And they were advised that they can stop the self-catheterization once they have had post-void residuals of less than 100 for at least 2 consecutive days. In this group of patients, it was also thought that some of the contributing factors to their their voiding dysfunction could be because of hypertonia of their urethral sphincter. So they were started on alphazocin for 4 weeks. To further stimulate their pelvic splanchnic nerve, they also inserted a Eurostim electrostimulation device by inserting some electrodes in the posterior tibial nerve. So in terms of results, so they had 1,900 patients, only 3.2% required self-catheterization at discharge. And amongst these group of patients, 61 patients, 70.5% of them stopped catheterizing during the follow-up period. They put them in group A, and 29.5% of them still catheterized at their last visit, and they put them in group B. And the follow-up between Group A and Group B, there was no significant difference. It was 114 weeks versus 107 weeks. So this table 1 shows the baseline characteristics of patients in Group A and Group B. Most of their baseline characteristics are similar, apart from their digestive symptoms and their urinary symptoms. So they looked at their GI scores using the GI Quality of Life Index and their KESS scores. And what they found was in Group A, they had a higher GI Quality of Life Index score and a lower KESS score, which means that this patient had better digestive symptoms compared to patients in Group B. And then in terms of the USP score, as I mentioned just now, the higher the number is, the worse the symptom is. The sum of the 3 questions. So in Group A, it's much lower than Group B. It was 0.8 in Group A, whereas it is 2.7 in Group B. This table shows the intraoperative findings and surgical procedures that were performed between Group A and Group B. There were no significant difference between those 2 groups. And then they also looked at the probability of needing to continue self-catheterization after surgery. So after 4 weeks, they found that 75% of patients still needed to catheterize. After 8 weeks, 46% of patients needed to. After 3 months, 41%, and then after 2 years, 31%, and after 78 weeks, it was 23%. So based on this table, what they concluded was that 77% of patients who had to self-catheterize after deep endometriosis surgery would eventually stop and regain their normal bladder function. They also did a Cox multivariate analysis looking at predictors that would contribute to stopping catheterization or continuing it. And what they found was the pre-op bladder voiding dysfunction was a significantly independent factor that resulted in continuation of the self-catheterization. So the 2 main points of this paper was this: patients with pre-op bladder voiding dysfunction are at higher risk of needing to continue self-catheterization, and this one where 77% would stop catheterizing stop catheterizing after their post-operative period. Yep, and that's all for me.
I love this paper. It's a really interesting paper. I've wrote a couple of questions that for the patients that had preoperative bladder voiding dysfunction diagnosed, was that diagnosed on urodynamics or just on history?
Oh, actually, it was literally just on that that urinary symptom profile questionnaire, and that's what they stated as one of their limitations of the paper. Actually, the reason why they didn't use urodynamics is because, number one, the the symptoms are intermittent, it's affected by periods. So if you do these tests outside your periods, or if patients are on hormonal treatment, you can get false negative results.
Okay. And for the patients that, do they, sort of another question is, do they anatomically, did they describe exactly where the endometriosis was excised, or was it just a general sort of?
It was described in this table too. Yeah,
So,
and they found that there was no significant difference between the two groups.
okay. And for the patients that were started on alfuzacin, they had a significant reduction of self-catheterization. What was the third line treatment for the group that was still self-catheterizing afterwards? Did they do sacral nerve root stimulation for those patients?
They didn't mention anything about that. They just mentioned that for all patients who required intermittent self-catheterization at discharge, they started on these two treatments immediately.
Okay.
Yeah.
That is
So-
an interesting paper. Mohammed, any comments from you?
Yes, I think here there is a very good take-home message. Many of us do not stop for a minute to ask the patients about their urinary symptoms. And I'm not sure how many centers utilize the questionnaires, different types and forms of questionnaires, to evaluate the symptoms preoperatively. It's important to evaluate preoperatively the voiding function, because first you can screen these 1,900 patients and find that out of them, for example, 100 would need urodynamic studies and further investigation and evaluation. Second, this is important for the patient now that we know that this is using a multivariate analysis. This is an important independent factor that would predict poor functions and long-term dysfunction after the surgery. So if the patient has a problem before the surgery, yes or not, has urodynamic alterations, but she knows that, madam, you are at high risk of developing urinary dysfunction after the surgery. You might need self-catheterization. This self-catheterization can happen for a long time. And by this, you gave her also the possibility to make an informed choice, because it's not only the patient that has bilateral parametrial involvement or segmental bowel resection. As we have seen, there is no significant difference between what happened with the surgery in both groups, A and B. Did I understand well, Avril?
Yes, correct, as what is seen on this table over here. So deep endometriosis infiltrating parametrium and then rectal surgical procedure.
Yes, so I think this is a very important take-home message to tell to our patients, but at the same time, not to scare them, because 77% of the patients recovered from intermittent self-catheterization within, and again, this is in, if we can say, one of the best hands. Yes, so it's an important message to give to our patients before the surgery, and a very important topic to take in consideration while we are doing symptom analysis before the surgery, voiding function and voiding dysfunction, I think.
Yeah, I completely agree. And I think the number of self-catheterization, even at the group that didn't respond to medications, goes significantly lower, if I remember correctly, even by 50% by sacral nerve root stimulation, even if it's done with radiology from the external route. So that's definitely needs to be taken into consideration. But also one aspect that I've always thought that we don't actually take into consideration too much is the patient's actually ability to self-catheterize if needed. I've seen quite a lot of patients recently that for one reason or another, they would physically not be able to self-catheterize, for example. And that's something that I think needs quite a lot of discussions in clinic. But very interesting paper. Thank you very much, Ahmed. Sorry.
Mikey, there is a question from the audience for you and Professor Mabruk. Is it possible to predict neurogenic bladder atony or motor bladder atony before surgery?
Is it possible to predict? So I think you've answered this question actually right on the beginning. The preoperative assessment and bladder questionnaires. There's probably a lot of those patients that already have bladder dysfunctions will continue having those bladder dysfunctions even before the surgery. I don't know, Mohammed, how you feel, but I I always concern patients for the worst and hope for the best. But yet again, I've seen patients that I've operated on that had significant bilateral parametrial infiltrations, and yet they still have completely normal voiding ability and sensation and ability to urinate. So I don't think it's a clear answer. I personally don't kind of understand exactly the mechanism of it. Maybe there's some neuroplasticity within the nerves, or whatever happens. But I think it's really difficult to predict. Looking at this paper, probably the best prediction is actually really good history beforehand. But Professor Mabrouk, what do you think?
No, I agree with you. I agree, and also a rigorous mechanism of evaluating these patients post-operatively. This is important because, yes, again, in best hands, you can also be, it's not just taking the catheter out, doing 3 talks and say, Madame, you're okay, go home. Because the big problem happens when these patients start to have retention. And when they start to have retention and bladder over distension, this is where there is a damage to the detrusor muscle. And unfortunately, after 7 years or 6 years or whatever, these patients have an irreversible damage. And it is not very easy to correct. And this is, again, something that we have to take in consideration. Recently, we were teaching and having some discussions about endometriosis post-op in deep endometriosis patients. And with a nice, very, very nice era of ERAS, we love it. People are very proud that they remove the catheter inside the operating room. So they remove the catheter before the patient goes out of the operating room. And that's it. And patient is just discharged on the same day. Well, that's okay for many surgeries, for hysterectomies, for straightforward whatever, adnexal surgery. But for deep endometriosis, look at the follow-up here. Look at how rigorous they are in their post-op, and they remove and they evaluate. And if it's more than 100, then they send them home with the self-catheterization and then bring them back. And it's a long dialogue where the patient is in the center, you teach her, and at the end you evaluate. And because if this system is not efficiently functioning, this patient might have, unfortunately, irreversible sequelae of bladder damage and dysfunction, which is, I'm not sure that's what we aim at.
Yeah, and that actually does happen. That's a really good point. That I think that even sort of discharging patients, I think we don't have a standardized language that all of us agree on what's the residual volume to send someone home. You know, you could speak to one specialist and they will tell you 100, and the next one will be 150. Even someone will go even higher. And sometimes those patients do pass talk. Bent, I don't know if you remember the lady from a couple of years ago that we did a really deep sacral nerve root sort of excision. She was having sciatica. The operation went great, passed her talk, but sadly, on day 2, I think, as soon as she got discharged, the following day, she went to A&E with a big bladder distension because she couldn't urinate. So all those ticks went by in the hospital, but when she went home, obviously that was a problem. But yeah, I really enjoyed good discussion. Right, should we go to Mohammed, to your presentation? So we've got Professor Mohammed Mabrouk, who is going to be presenting this paper on diagnosis and treatment of uncommon ileal endometriosis, case report and literature review. Mohammed, over to you.
Oh, thank you very much. You can see my slides, no?
Yeah.
Perfect. So very quickly, it is diagnosis and treatment of uncommon ileal endometriosis. And I will just try to explain to you what and why it is uncommon and summarize this case report with important take-home messages and speak about the literature review about this situation. So, sorry, I have some asthma. Anyway, so bowel endometriosis is not uncommon. So bowel endometriosis, of course, the rectosigmoid junction and the sigmoid colon are the most affected parts. And the higher you go, the more proximal you go, the lower is the lesion, except when you are very low, when you're near, again, the pelvis, in the appendix and in the ileocecal junction and in the ileum. So the appendix is 6.4%, and the ileum and ileocecal junction is about 4.1%. Is it continuity? Is it contiguity? Is it whatever? We don't know. Obviously, this is a £1 million question again, how it arrives to the ileum. But let's say that it goes there. And if it goes there, you will ask me, you said unusual presentation of ileal endometriosis. So what's the usual appearance of ileal endometriosis? And let's go through the take-home messages. At laparoscopy, this is the typical ileal lesion. You can see it as a nodular lesion like this or like this. The typical position is within 10 centimeters from the ileocecal junction. So either you find it as a nodular lesion this way or that way, or you find it as an endophytic growth, like the rectosigmoid and the sigmoid, where it goes and makes an endophytic growth like this one or that one. So these are the typical appearances at laparoscopy. So why did I say uncommon or unusual in my paper? Because this is what we found. It was exophytic lesion, as you can see here. So it's not an endophytic growth. And it wasn't within 10 centimeters. It was about 40 centimeters from the ileocecal junction. And this will take us to more uncommon or unusual presentation of this case. So how do they present? How do ileal endometriosis present? Then we knew first that it is not uncommon. It's not very rare. It is possible. Patients with ileal endometriosis usually are asymptomatic. But when they have symptoms, these symptoms are significant. We all listen to our patients and we analyze their symptoms. And many patients say, yes, I have bloating, I have cramps, etc., etc. The point here with ileal endometriosis is that when they have these symptoms and they're really significant, and when you don't find any bowel endometriosis, this obviously can be due to a lot of things, but it can draw your attention when this patient has all this and you don't find anything on the usual imaging. We don't have, for example, there are centers who do only ultrasound for diagnosing endometriosis and operating endometriosis. Other centers who do MRIs. With MRI, especially in expert hands, you can see it. And if you have doubts, you can ask for entero MRI. But with an ultrasound, this is not one of the easy points to diagnose. However, I know that in certain centers, they also diagnose the appendix, the ileum, and everything. But this needs a very high level of expertise. Diagnosis, unfortunately, as we will see in the review of literature, is usually made incidentally during surgery. So most of these patients have vague symptoms, have symptoms that you don't correlate with the ileum, and most of them, you diagnose them during the surgery itself. But unfortunately, some of them, you diagnose them with a direct complication, as we will see. So these patients can express themselves first as bowel obstruction, acute small bowel obstruction, as intussusception, or as perforation, as we will see. So what is the point and what is our case? Our case is 41 years old and she's multiparous, had dysmenorrhea, dyspareunia, dysuria, and in the last 6 months, as you can see here, she had resistant to progesterone therapy, but the key point in this paragraph is perimenstrual intestinal bloating. Is one of these patients that says every time around my period, I'm 9 months pregnant. And she had, this is the second point. She recently had diagnostic laparoscopy somewhere. And with the diagnostic laparoscopy, she has been diagnosed as bladder endometriosis. And this ileal endometriosis has been missed even with diagnostic laparoscopy. And this is the second take-home message. Third take-home message, ultrasound didn't show, neither ultrasound nor MRI. They showed uterosacral ligament endometriosis and bladder dome endometriosis. And because of these symptoms, and this is also an important take-home message, her symptoms were suggestive that there is something wrong. We counseled her that if we find something related to the appendix or to the small bowel, we will deal with it. And she gave us the consent. And this is what we found. So this is, as you can see here, this is the ileum, and at a distance of about 40 centimeters from the ileum, there is this exophytic lesion that was there, and obviously responsible for most of her bowel symptoms. So perimenstrual intestinal bloating, she had already a diagnostic laparoscopy that missed. She had an ultrasound and MRI that missed. And during the only good thing here is that before surgery, we counseled her about the possibility of dealing with the appendix or the small bowel in case there is something. Looking at the literature, I will try to summarize what we can find in the literature regarding this topic. We made the review of literature. The first case actually is published in 1956. And we found a total of 63 cases of ileal endometriosis. 11% of them presented for the first time with acute bowel obstruction. One case presented with spontaneous enterocutaneous fistula after bowel obstruction. Diagnosis of ileal endometriosis was made during surgery in about 68% of the cases. So 68% of the cases had no diagnosis before surgery. And interestingly, in 14% of the cases, there was no endometriosis elsewhere. And these patients who were followed up, 95% of them had improvement of their symptoms, and only 11% showed some change in bowel habits after surgery. I mean, change is a change. It can be constipation. It's a negative change, not a positive one. It's not that they felt improvement, but some of them had constipation, diarrhea, and different symptoms. It's not uniform what they had, but most of them had a bowel resection, a small bowel resection. And surgically and technically speaking, also what we did here in this case is when you have the lesion away from the ileocecal valve, this is a good thing, because what happens is that you resect only a small part of the ileum around the lesion. But sometimes when it is involving the ileocecal valve, or the so-called valvula di Valerio, this one you have to resect also a part of the cecum. Some centers call it typhlectomy, because you resect the terminal ileum with the pouch of the cecum, or sometimes you have to extend a little bit higher, and this is a sort of partial right hemicolectomy. And obviously, according to the extent or according to the presentation, if the patient is presenting in acute obstruction, is different from if you are operating on her electively. And in conclusion, I think that most cases of ileal endometriosis can be overlooked during preoperative workup. It's important to have a high level of suspicion, especially when these patients have significant bowel symptoms and with no evidence of any other bowel disease. And the preoperative counseling is important about the possibility of appendix, ileal, or ileocecal resection during the surgery. And more importantly, to remember that these patients can present with acute intestinal obstruction, and to bear in mind that an endometriosis patient is not usually, when she comes to A&E, is not usually the, oh yes, this is an acute flare-up or whatever, some morphine and send her home. They might have serious complications. And I think also one of the very important take-home messages is to have a method in diagnostic laparoscopies. I'm sure we all have seen this 3 minutes diagnostic laparoscopy when you put one trocar and move a little bit, look to the ovaries. Yes, everything is okay, madam, you don't have. When you have a method in diagnostic laparoscopy, you check the diaphragm, you go down in a clockwise, anti-clockwise, do it as you want. Look, but not only to the appendix, but to the cecum and the ileocecal junction, because these are positions that can make a difference in the total or the overall management of the patient. Thank you very much.
Brilliant. Thank you very much, Mohammed. Lovely presentation as always. Maybe we can take some questions. I know you need to leave a bit earlier. So if we have any questions for Professor Mabrouk, please type it down, or you can even raise your hand. Shaheen, do you have anything to add? Are you okay to speak? No?
Thank you so much, Professor Mabrouk. It was really nice, this
Thank you.
presentation.
Thank
Can
you.
I ask a quick question?
Please.
So in your patients that they have bowel symptoms and things, would it be routine for you during the diagnostic phase of your laparoscopy to say like walk the bowel and things?
Well, in diagnostic, let's start by, we don't do diagnostic laparoscopies. But we do, the first phase of laparoscopy is, we call it the diagnostic phase of the laparoscopy. And in the diagnostic phase of the laparoscopy for endometriosis, we do this as a routine. We go to check the diaphragm, we then go down, we mobilize the bowel, we free the pelvis, all the small bowel up, look to the appendix, look to the cecum, to the ileocecal junction, and then go to the pelvis, look to some key points in the pelvis, starting from the ovary, blah, 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 blah. Take it all, clockwise, anti-clockwise, anterior, posterior, posterior, the way you want. But the important thing is that you have a method, because otherwise you may miss something. And this is, again, if you miss a small lesion, I don't know where, in the bladder, for example, yes, it's important, but you missed it, it's not a huge deal. But this is a lesion that can cause the patient an important complication like acute intestinal obstruction, etc.
And also maybe to add is whenever you start your laparoscopies, right, your small bowel will mostly be in the pelvis, so but automatically you would see majority of it before you actually put your patient in transpersonal position to move the bowel back. So without you even knowing it, you're running the small bowel, a majority of it, before you even start the surgery. Mohammed, in your sort of experiences, you obviously are one of the most experienced surgeons nowadays. How many of actually cases like this, what you've just showed us, have you seen, both in here and in Italy?
Well, this is obviously one of a rare case, and this is the reason why we made a case report. But ileal endometriosis is not uncommon. This is it's not very uncommon. It's not uncommon. Now that, for example, when I started in Cambridge, I have a very interesting case. Yes, we have the MRI service in Cambridge is amazing, and they look to the right hemipelvis and they go up to the appendix and as a part of their study. So they do it as a routine. And when they say there is something, yes, there is something, and then we start to follow it. But also, if you say to the MRI doctor, I suspect because she has severe bloating, severe bowel symptoms, etc., etc., she goes and maybe she focuses more or looks more. You know what I mean? But we had a patient. This is interesting. Let's say that this patient had endometriosis for a long time. Fine. Pills, okay. Symptoms are managed, okay. All the symptoms, no. Bloating and intestinal symptoms are not managed. Fine. She did the MRI. Addenbrooke's MRI said ileal lesions, 3 nodules. Fine. She was a bit worried, a bit. Anyway, at the end, we convinced her to have her surgery. Fine. She had her surgery, 3 consultants coming on the day, in the morning, blah, blah, blah. She said, well, I had my bowel preparation, but I have severe pain. Okay. We said, maybe this is the bowel prep. We go inside, do laparoscopy. There was something like half a liter of pus in her tummy.
Wow.
And this was a suppurative appendicitis. We removed the appendix and we couldn't operate because the rest of the ileum was really inflamed. Fine, we will not. But then we operated on her, something like 2 months after. And surprisingly, she had this and a little bit of endo on the uterosacral ligaments, etc., etc. Symptom-wise, she is perfect. She is very, very good. So my conclusion is ileal endometriosis is not very uncommon. It's not very uncommon. It is there, but this case is a bit rare. But ileal endometriosis is not very uncommon. It's obviously it becomes more complicated when you have a colon endometriosis, the descending colon, and the ileocecal, and then you have to do double resection, etc., etc. But it's not very uncommon.
There's a question from Dr. Mokit. It's a question about shaving ileal endometriosis, if it's recommended or not.
Well, this is also a difficult one, but I don't think it is recommended. But when it is very, very superficial, very superficial, it's just on the serosa, maybe, but I don't think it is recommended because the small bowel, the caliber of the small bowel is very small. It's tiny, especially if you have an endophytic lesion. You shave as you shave, but you reduce the lumen, and I'm not sure you're doing a great favor. The ileum is very long, and you take a small piece of it with the lesion included. And this is what I have seen being done with all the cases, actually. Have I seen shaving? Yes. How many? A case maybe when it was a very superficial thing and just on the serosa with scissors, you just shave it and give a stitch, superficial stitch, and that's it. I'm not sure if this is your experience as well.
So I have never seen actually shaving of the ileum of small bowel. Shaheen, have you? No. I always think about it in a way that, you know, even in the worst case scenarios when you've got some sort of injury to a small bowel, you know, most of the time it is a resection and anastomosis rather than suturing, because it purely comes down to anatomy and the thickness of the bowel wall. So that's what it is. So shaving is really not really feasible, but I don't have that much experience with small bowel lesions, to be honest. The ones that we've seen has always been resections. Shaheen, how are you? Are you on a train?
Yes, I am, but we're just about to arrive. So maybe in a couple of minutes I can start talking.
Okay,
but
fair.
I'm really enjoying this.
Good.
Thank you, Shaheen. Thank you very much for the invitation. Thank you.
All right. Professor Mabrouk, I know you need to shoot off, so if you want to, you're more than welcome to stay for the rest of Legendo. If you want to shoot off, we completely understand that it is Saturday, it is the evening, England is still playing. You might catch the last 5 minutes of the game.
I know, but I'm here. No, I'm with you for still some time. Thank you very much.
Right, we still got two small papers that are quite interesting, actually. So let's go and get them done. Avril, is it?
Can I say something, Mikey?
Right.
Yeah. No, first, I wanted to thank Mohammed. It was a very interesting case, and thanks for accepting our invitation. It was a pleasure listening to it, even though I couldn't talk. It was. Just to mention a couple of things. One is, what would you think is the best way to manage an incidental finding if there is no significant symptoms?
If you have I think, Shaheen, if you have a consent for this, if you consent the patient that you can manage and she gives you the consent, then you can. If not, I think that we can take pictures and make this as a diagnostic laparoscopy, take pictures and then explain to the patient, we found something that more than what we were expecting. This answers the questions for your symptoms. And I think you need another type of surgery. This is the surgery. This is the counseling for it. This is the expected risks and complications, etc. And we reoperate on her again.
Yes.
In another
And whilst we're discussing unusual presentations, we also recently saw a very unusual presentation of involvement of the ileum over around 100 centimeters.
Wow.
Multiple, maybe 30 lesions spread over around a meter of the ileum, starting from the appendix going on. But we're managing it conservatively for now.
Yeah, that makes sense. That makes sense.
Yeah.
If it is 100 centimeters, 30 lesions, you will not remove all her ileum, especially if she doesn't have symptoms. You made, I think it makes a lot of sense, especially if it is just a lesion and it is not causing her any narrowing of the lumen or anything like that.
Yes, I think so. Well, there weren't many options anyway, but yeah, thank you very much. I will listen.
I do remember this patient. There was a lot of small lesions on the small bowel, a lot, and it was a vast area of it as well. Right. Let's go to the other two small articles, guys.
Cool. So this next one is another meta-analysis that is looking at deep brain stimulation for chronic pain, a systematic review and meta-analysis published in Frontiers in Human Neuroscience in 2023, so last year. This article sparked my interest because chronic pain is obviously something we come across a lot as gynecologists, and for those patients where you've had a look and actually you can't see anything on laparoscopy, what do you do next? So if we go to the next slide, please, Avril. This meta-analysis examined the effectiveness of deep brain stimulation. I'm just going to refer to it as DBS from now on in the treatment of chronic pain. Deep brain stimulation was evaluated for chronic pain treatment with 2 different subject groups identified for DBS for chronic pain, so DBSP, and then DBS for other indications labeled DBSO for things like Parkinson's disease or dystonia, where pain perception was a secondary outcome. This included 966 patients from 43 original research studies, where 340 underwent DBS for chronic pain, and then 625 patients in the other group. And what this meta-analysis revealed, that there was a significant effect of DBSP on chronic pain relief, emphasizing the positive impact of DBS in managing chronic pain. And despite substantial heterogeneity among the studies, the paper found no significant difference in chronic pain relief between the DBSP and DBSO subgroups, indicating similar sort of effectiveness in pain management across the different conditions. So we can go to next slide, please, Avril. For this meta-analysis, they performed a systematic literature search conducted using PubMed, Scopus, Web of Science, and following the PRISMA guidelines with a well-constructed search strategy used. The meta-analysis was performed using R version 4.2.3 software, and then they assessed for heterogeneity using tau squared and chi-squared indices along with the Cochrane's Q test. The analysis included 966 patients, as I said, with subgroup analysis conducted based on study design, age, pain diseases, and brain targets to evaluate the effectiveness of DBS in chronic pain management. Next slide, please, Avril. Subgroup analysis revealed a significant effect of DBSP on chronic pain relief with a standardized mean difference of 1.65 and a 95% confidence interval of 1.31 to 2. So how can we interpret this data? Well, the 95% confidence interval indicates the range within which the true effect size of deep brain stimulation for chronic pain relief is likely to fall with 95% confidence. It suggests that if this study was to be repeated multiple times, 95% of the time, the true effect size would lie between 1.31 and 2. And then the narrower the confidence interval, the more precise the estimate of the effect size, providing a better understanding of the treatment's effectiveness. And so in this case, the narrow confidence interval of 1.31 to 2 indicates a relatively precise estimate of the effect size, so we can be more confident in the reported findings of the study. There was a notable heterogeneity with an chi-square value of 85.8%, but there was a consistent effect size, and this highlights the overall efficacy of deep brain stimulation in providing relief for chronic pain. And then they did meta-regression analysis, which did not find a significant relationship between age or pain duration and the effectiveness of DBS for chronic pain. So this highlights the need for further research to understand sort of patient-specific factors that might influence the response to treatment. The significant effect size sort of underscores the promising role of DBS in addressing chronic pain conditions. And these are often resistant to conventional therapies, and this offers new possibilities for improving pain management outcomes. And finally, to the conclusions. So I think that we can conclude that deep brain stimulation does demonstrate a significant positive effect of reducing chronic pain, Although not statistically significant, I don't think, there was a larger effect size observed in the DBS-P group compared to DBS-O. It's been seen in this meta-analysis that age does not significantly impact the effectiveness of this for chronic pain relief. And this highlights its potential for use across different age groups of patients. And the meta-regression analysis revealed no significant relationship between age or pain duration and the effectiveness of DBS for chronic pain, suggesting that these factors might not influence treatment outcomes significantly. But what I'd like to see now are trials that investigate the effect of DBS in chronic pelvic pain patients, because this study focused more on the use of DBS in conditions such as cluster headache or facial neuropathic pain. But it's certainly an exciting prospect for the treatment of chronic pelvic pain.
Right. So I really love this subject. For me, this, as Shaheen would say, it's a hobby horse. I've got two neurosurgeons in my family, and both of them, they basically both of them specialize in DBS. And as far as some of you might know, he is I would say, one of the first people in Spain who started doing DBS for Parkinson's, and so is her brother now in Barcelona. And we had those discussions over and over and over again. And Charlie, tell me, in this study that you saw, this was mostly for facial pain, right? Did they do any preoperative sort of MRI mapping to see where the implant was placed, or was it placed in exactly the same place as they would do for DBS-P patients?
So obviously this was a meta-analysis, so it was more a combination of all the different studies. So I didn't see what the exact protocols were, sort of pre-op and things, but there was also, I didn't include it in my slides, but there was a table which looked at all the different areas of the brain and the different nuclei that they inserted the stimulation probes in, I guess. So it was varied, I think, between the different studies. There wasn't an overall protocol that each one followed.
So the papers that I've seen were showing, the limited papers that I've read on it were showing about 50% improvement in patients with chronic pelvic pain for whatever pathology that was detected. So we're talking about pelvic pain for unknown reasons, for endometriosis of the excisions, etc. And they were quoting about 50% chance of pain reduction. There's also a very interesting publication that came out of Germany recently, where they looked at nerve stimulation. So we're talking about the Lion procedure for pelvic pain, and they were showing 85% reduction of pain for specific patients that they were choosing. So I think there's a lot that we still don't understand. But Mohammed, you guys in Cambridge, when you were there was quite a big department for deep brain stimulation. Did you guys ever work together with them at all, or was it a completely different departments where you didn't have anything to do with each other?
Unfortunately, completely different. But again, this is another interesting study that would make me think, like the probiotics and symbiotics. It is a very good opportunity, because if you have it there, it's just you need to go and knock the door and communicate and ask.
Yeah, so from the limited research that I did, because we've been talking about it for a number of years now, the team in Cambridge seems to be already set up for it. I know Shaheen has a good friend in London that does it as well. But I think it's an opportunity for those patients that we have no answers to why they are in pain. And you know that sometimes the road ends with us saying, well, I'm sorry, I don't know where we can go from now on. And I think this avenue of deep brain stimulation or not peripheral, but sort of Lion procedure nerve simulation potentially has some benefits in it. There's certainly, we need to have more data on it, and we need to have at least a good trial of it. But I would put my money certainly on deep brain simulation. I think the trick is really to just realize where the pain simulation is and where to put the electrodes in the brain. That's my couple of cents on it. Okay, do we have any questions on this? Shaheen, do you want to add
No,
anything?
I think maybe we can watch a couple of videos and do it us. Yeah, I just wanted to say maybe we can watch a couple of videos and do it ourselves, huh?
Yeah, well, I'll tell you what, when I went to watch Pedro in Barcelona doing it, they took honestly, about 3 or 4 hours positioning the patient with the MRI on the table. By the time they actually started the operation, I just went to the beach because it was already lunchtime.
That's no problem. We just get an MRI in the operating room and we put them in the brain. How difficult could it be?
But for the Parkinson's patients, it is quite impressive to see the shade stop, etc. But for chronic pelvic pain, I think it's a slightly different approach. But it's very interesting. All right, Avril, are you gonna go with your last one? You muted.
Yes, my last one is quite a small study, again done by a team from France, looking at the risk of anastomotic leak in patients who have low colorectal resection for endometriosis and adenocarcinoma. So, retrospective cohort study, they collected data on patients who had a low colorectal resection, that means less than 7 centimeters from the anal verge. Performed between September 2018 and January 2023, and the indications were endometriosis and rectal adenocarcinoma. So table 1 describes the characteristics between the two groups. So we have 99 patients in the endometriosis group, adenocarcinoma, we have 60 patients. The main difference between the two groups, apart from their clinical parameters, is age. So in the adenocarcinoma group, the mean age was 63, whereas in the endometriosis group, it was 35. In terms of the intraoperative findings for the endometriosis group, so 75.8% of them had Enzian C3, that means rectal nodules measuring more than 3 centimeters. 37.3% had A3, and 59, so almost 60% had B3. Whereas in the adenocarcinoma group, we had almost 83% with cancer stage 3 or 4. 23% had distant metastasis, and 63% had adjuvant chemotherapy, and 55% had 55% had adjuvant radiotherapy. So what they found was the rate of leak was similar between these two groups: 12% in the endometriosis group, 15% in the adenocarcinoma group. When they looked at the risk of leaks in patients with endometriosis, it was found that those with vaginal wall involvement more than 3 centimeters was significantly associated with the leak. Whereas when they did the multivariate analysis in patients with adenocarcinoma, it was found that those who underwent neoadjuvant radiotherapy was found with a significantly increased risk of leak. And when they did the global multivariate regression analysis, what they concluded was an anastomosis height of less than 5 centimeters was associated with a leak, whereas a protective stoma was significantly associated with a decrease of the leak. So the conclusion from this study was, despite these two groups having different pathologies, the risks of leak in these two groups are actually the same, which then further encourages us to now look for further risk factors that could increase the leak in patients with endometriosis, because these patients have not undergone radiotherapy, which is known to affect the intestinal tissue, affect wound healing. They are much younger, which you expect the healing to be better. But why is this group having more leaks? So that was what they concluded from this study.
That's quite interesting, huh? So Avril, can I clarify? So they only included patients who had anterior resection that was lower than
7.
Lower than 7 centimeters.
Yeah.
Okay. So
I guess that's what could explain their high rate of leak, because 12% is a bit high, isn't it, compared to like the normal ones in the literature, which is like 1 to 3%.
Yeah, well, in the literature you can get higher rates. It's quite variable, but Mario's data shows less than 1%. Our data, which, by the way, congratulations for the acceptance of the paper, Avril. Our paper shows 1.8%, and actually that's not just leak. That includes, I think, one case that wasn't a leak but still was a 3D complication. So 12% is high, but we didn't separate our leak rates between low and high. I don't know. What do you think, Mohammed? Is this a number that you would think is a usual leak number for low stenosis?
Well, what is surprising for me is, yes, the high incidence, but also that the same group, low resection, less than 7, same complication rate between patients with endometriosis and cancer, despite neoadjuvant chemotherapy, radiotherapy. 37, the mean age is 37 in one group and 63 or something like that in the other group. So this is, for me, is a bit surprising because, yes, you don't expect a high rate like this in, even if yes, even if it is less than 7 and everything. They also did stomas because they said, yes, stoma. So, I'm not sure. Yes, vaginal more than 3 is.
It's interesting. Do you think that it's a bit of a strange comment, but do you think that then we need to look potentially at the surgical techniques that are used? Is there attention there on the anastomosis? Is there a leak is normal when
Could it
others
be explained by their enzyme C3 being like almost 76%?
Yeah, but if it wasn't C3, you wouldn't be doing anterior-recess.
Yeah, you'll be doing it.
So I would even question that if you have C2, why aren't you doing a disc? Because if it's less than 3 centimeters, then you shouldn't be doing a segmental. So by definition, segmental is for C3. So even that 25% I would question. I don't know. It's I think, first of all, the fact that they have been doing these large numbers, I think that means that they are experts in the field. It doesn't always follow, but I think it's safe to assume. The fact that they've published this data, I think, is commendable. And it's, maybe it was just a bad patch. But I agree that with the current evidence and the current surgical technique, we expect to see much lower leak rates. And our data has been in line with that. I think, maybe this has been a bad patch. And I think the other point that Mohammed also made, we now have good data from Horace's team that actually, when he compared his leak rates before and after he stopped doing ileostomies, he found no difference at all. So ileostomies really don't prevent leaks; they just make them less dramatic. So I certainly wouldn't conclude from this study that you should be doing more ileostomies. I don't know what you guys think, Mohammed.
I agree with you, Mohammed.
Yes, I agree. And I just think that maybe because it's a big number, I'm just trying to find an explanation, but yes, ileostomy shouldn't be the answer. Shouldn't. Yes. But yes, maybe there is another answer. Maybe ICG. Maybe, I don't know, maybe less tension, maybe, I don't know, but 12% is high. And similar rates to adenocarcinoma, with all the respect and with all the comorbidities and and radiotherapy and chemotherapy and all these things is a bit high. And obviously, yes, they are. We have to commend that they publish this, but we need also to understand, maybe for us to improve our practice, why the explanation.
100%. I completely agree with the last statement. There was a message from our friend Ahmed Kali, who was just commenting that for diaphragmatic endometriosis, sometimes it's difficult to visualize the lesions behind the liver. Therefore, MRIs are very useful, which we completely agree with. We're coming to the end of the session now. I know it's Saturday. Everyone wants to enjoy the evening. Thank you very much again, Professor Mabrouk, for joining us. Thank you,
Simon, for the invitation. Thank you
for being here. Thank you to all the friends, colleagues, patients, and advocates that joined us today. I wish you a lovely Saturday. I don't know if England won or not. Did they? Does anyone know?
1-1.
1-1. But what are they in penalties now? Or?
Oh no, extra time.
Extra time.
Ooh.
Okay.
Okay, go and see the extra time.
Everyone.
Let's go.
Okay, bye.
Okay.
Bye.
Have a good evening. Bye bye.